So obviously for the indomethacin-responsive headaches, such as paroxysmal hemicrania and hemicrania continua, indomethacin is the key to diagnosis and also treatment. Still, indomethacin is an anti-inflammatory that is not always very well tolerated, can lead to a lot of gastrointestinal effects or hypertension issues. And therefore, other options have been looked at, especially the supplement called Boswellia serrata or gliacin has been shown to be helpful in some patients who respond well to indomethacin. Other anti-inflammatories, for example, celecoxib or naproxen, can be used, but with very modest effect. The occipital injections I was mentioning before with cluster headache can also be effective for the indomethacin responsive headaches. And then you can use a lot of things completely off-label that go from gabapentin to botulinum toxin injections to try to control those headaches that can be extremely disabling. The special case of SUNCT is a completely different story because it looks a lot like trigeminal neuralgia, actually, this condition. Attacks are very brief. And the first thing that we use usually will be Lamotrigine, an anti-epileptic drug. Other drugs that have been reported include the other anti-epileptics such as Carbamazepine or Carbamazepine. And also lidocaine infusions have been described to help with SUNCT. Same thing for procedures. So there's actually very good reviews showing all of this and the long list that can be tried. But SUNCT is a notoriously refractory condition. So if you try the whole list and it still doesn't work, once again, a referral to an appropriate headache specialist. And at this stage, even a specialist, sometimes we struggle with SUNCT and more options are needed. As a last resort for those options, all of them, neuromodulation has been tried. So there is for cluster actually a gamma core, which is a nerve vagus non-invasive vagus nerve stimulator. The problem with this option is that it's not available widely in the planet, and it's mostly in North America and Europe. It is costly and not super convenient, but it is a very safe option. And then you can implant electrodes, so you can do either implanted occipital nerve stimulation or even inside the brain, so deep brain stimulation in the hypothalamic tract. Both of these require experience with neurosurgical teams and a collaboration with an expert in those diseases. Very few centers have access to this, but the response rates are estimated to be up to 50 to 60%. So talking about extremely refractory patients, neuromodulation options still have their place.